Assalamu alaikum. Welcome to my presentation on cystic fibrosis. I am Dr. Ahad Adnan from ICMH Bangladesh. The term cystic fibrosis was first coined by Dorothy Anderson on 1938 when she found a cystic lesion in an organ surrounded by some fibroblast, and interestingly, that organ was not lungs, it was pancreas. So it is an inherited multisystem disorder and one of the most common life-threatening recessive genetic trait. The patient who survived their neonatal period have pulmonary complication in 90%, and the principal cause of death is end-stage lung disease. The CF gene codes for the CFTR protein, which is located in long arm of chromosome 7. Till now, more than 1500 to more than 2000 mutations have been recognized. And whatever the problem, there are basically 6 problems occur after mutation. Either there is no functional CFTR protein, or there is a trafficking problem, or there is channel regulation problem, or conductance, or even reduced synthesis or decreased CFTR stability. If we understand the pathogenesis of the cystic fibrosis, normally in violet color there is a chloride channel, which is a ATP driven channel. The function of this gene is to propel chloride from the cell into the lumen, and not only the chloride, it also drives sodium and water also. But if this gene is mutated, no protein will be formed and there will be no chloride ion excretion in the lumen. But another paradoxical thing occur in the gland like sweat gland or sebaceous gland or even saliva, where you can see chloride ion is normally passing in the luminal area, and the normally CFTR causes this chloride entry from the lumen into the cell. So when it is mutated, this chloride ion remains in the secretion, and there will be high chance of evaporation of this chloride into the atmosphere. So ultimately you can see in the net effect there will be decreased chloride ion secretion along with increased sodium absorption, and decreased bicarbonate secretion causes low pH. These two things causes mucus to be viscid, and the pathological bacteria find a favorable condition to harbor and cause repeated infection. At the same time, there will be decreased thiocyanate secretion and glutathione secretion, which are needed for bacterial killing. So there will be bacterial killing will also be hampered, and ultimately repeated infection, inflammation occurs, and the airway destruction even and remodeling will be occurred continuously. So let's see system-wise problem. First with respiratory system. In the earlier age, the smaller airways are affected initially, like a feature of bronchiolitis or reactive airway disease or even bronchial asthma like feature. There will be large amount of goblet cell hyperplasia. Why? Because due to body homeostasis, this thick secretion in the mucus will be compensated by profuse watery secretion, and we know the function of goblet cell is to produce this secretion. So ultimately there will be goblet cell hyperplasia. In long-standing disease, bronchiolar obliteration, bronchiolectasis, and bronchiectasis become prominent, and there will be cyst, bulla, or bleb formation, and they are often prone to be ruptured and cause pneumothorax. And sometimes bronchial arteries are enlarged and tortuous and have a chance to be ruptured and cause hemoptysis. The paranasal sinuses are also affected with repeated infection, and epithelial lining display hyperplastic or hypertrophic secretory element, and erosion of bone have been reported. So in infancy, cough viral infection like cough infection with some bacteria, you can remember a mnemonic called BCPS, BC for Burkholderia capacia, P for Pseudomonas or even Pneumocystis cerevisiae, and S for Staph aureus, and also Haemophilus influenza and some fungus also. You can see in earlier age, bronchiectasis is less common, 10%, but when in childhood and adolescent, it increase in number. And another common problem is allergic bronchopulmonary aspergillosis, that is a fungal infection. The GI pathology are mainly in two types. Either there is a mechanical problem by thick mucosal secretion, and another is decreased formation of enzyme causes malabsorption. So this secretion This thick secretion can produce blockage in the narrower part of the GIT, like esophagus or ileocecal junction, etc. And the gallbladder remain hyperplastic and filled with mucoid material and often contain stone. The pancreas, in endocrine pancreas, it's not diabetes is not common until the second decade of the life, but in more than 85% cases, exocrine pancreatic insufficiency occurs and causing frequent bulky greasy stool and FTT also. So I have a quiz. A 5-year-old boy, known case of CF, getting treatment with GRD, now complains of sudden intense dysphagia. What will be the most appropriate next step? So the problem is esophageal atresia. That is very much a common problem due to thick mucus infection in the lower esophagus, and the treatment should be endoscopic dilatation of lower esophagus. So this is the GIT aftermath. Genital system pathology in summary. Virtually all males are azoospermic and the female's fertility rate is diminished. Another quiz. What is the most common acid disorder in cystic fibrosis? As we know, there will be hypochloremia, and due to this hypochloremia, our kidney will act, and ultimately bicarbonate of ion will be secreted into the blood and causes metabolic alkalosis owing to chloride loss. So it shows present with hyponatremic, hypochloremic metabolic alkalosis, as I have said, with excessive loss of salt in the sweat predisposed to salt depletion, especially during acute gastroenteritis and during warm weather. And frequently patient notice salt frosting of the skin or a salt taste when they kiss the child. Skin may be salty, acute dermatitis enteropathic like rash due to secondary malnutrition causing zinc deficiency. In blood, hemolytic anemia due to vitamin A deficiency may occur with feature of infection, platelet hyperactivity and aggregation. So investigation antenatally for the indicated person, chorionic villus sampling or amniocentesis may be done with antenatal ultrasonography, shows some typical feature or signs. Newborn screening include elevated serum immunoreactive trypsinogen, and when it is positive, it warrants sweat chloride test. The sweat chloride test, it involves using pilocarpine ionotrope to collect sweat and performing chemical analysis, and more than 60 millimolar per liter of chloride is diagnostic, though it has some false positive and false negative test. One of the important thing is malnutrition, which falls in both group. DNA testing for 23 recommends at least 23 CFTR pathogenic variants. Nasal potential difference, it is included in the diagnostic criteria. Pancreatic function in indicated person. Chest X-ray, as I've said, initial feature is a feature of bronchiolitis or asthma, hyperinflation of lung, followed by hilar lymphadenopathy. Sometimes transient improvement occur, but ultimately there is bronchiectatic change with atelectasis or other changes. CT scan of chest, we have to focus on abnormal mucus plugging, airway, abnormally dilated air trapping or call-offs, typical infection, especially fungal pneumonia. So other investigation may be done in indicated persons. So this is the diagnostic criteria. Management, this multidisciplinary approach should be applied. General approach is to provide proper nutrition and adequate hydration with pulmonary therapy, vitamin supplementation, and guided antibiotic therapy. Inhalation, we can give human recombinant DNAs, which will thin the mucus plugging, and also hypertonic nebulization may be done with chest percussion with or without postural drainage, along with controlled breathing technique or routine aerobic exercise. Antibiotic therapy like that. And one of the common organism is Pseudomonas aeruginosa. And aerosolized antibiotic therapy like tobramycin or even astridinum or amikacin can be given. Bronchodilator therapy as bronchial asthma. And along with steroid, azithromycin 3 days per week may have some anti-inflammatory effects. And treatment of other complications like atelectasis, need aggressive antibiotic, hemoptysis, may need surgical procedure, pneumothorax with chest tube drainage, allergic bronchopulmonary aspergillosis with oral antifungal or other problem. pancreatic enzyme replacement have several effects. Vitamin supplementation, especially fat soluble vitamin and trace element like calcium and sodium. Meconium here, contrast anemia have both diagnostic and therapeutic role. Dios here, pancreatic enzyme replacement can work with a stool hydrator. Rectal polyps here also, pancreatic enzyme have role. Manual replacement can be done. There are other issues like hepatobiliary disease or diabetes, hypertrophic osteoarthropathy, polyp, salt depletion. So there are newer techniques, CFTR modulator therapy, the small molecule taken orally that correct the process and function of variant CFTR protein, and they reduce or correct disease manifestation like EVACA factor, LOMACA factor, or combination TESACA factor, LXACA factor, etc. So some studies shows recombinant human growth hormone have some effect in improve pulmonary function, increase bone mineral content, and reduce the hospitalization rate. So you can say over the last 3 decades, the severe FEV1 decrease is minimized, and normal FEV1 is increased day by day. And where the life expectancy was around 30 years in 90 to 94, now it reaches above 50 years. So thank you.